All right, thank you so much for staying with the Monday Report. The discussion starts right now on this day of the World AIDS Day. And I have my panel of experts here with me, starting from my farthest right, that is Dr. Samuel Kinyanjui. He's a country program director, AHF Kenya. Thank you very much for making time. Next to him is Dr. Lois Ombajo, infectious diseases specialist and co-director, Center for Epidemiological Modeling and Analysis at the University of Nairobi. Thank you for making time. Next to her is Dr. Stephen Dolo, director, Health Promotion and Program Management at the National Syndemic Diseases Control Council, that is under the Ministry of Health. Thank you for making time. And Cleopatra Wanjiku, HIV advocate and founder, the voice of a black child. Thank you very much for making time. And Dolo, I'll start with you. What are the numbers telling us?
Thank you, Trevor. Good evening, Kenyans. The numbers of the HIV infection are showing a general trend of declining. If you look at where we were 5 years ago in 2019 and where we are today in terms of new infections, they have declined from 41,000 to the current 19,000. That's the overall trend. If we look at the people who are on care, currently we have 1.3 million on care. And in terms of success in treatment, there's something we monitor called 95 target. If we look at the first 95, we have 97% of the people living with HIV who are already on treatment. Then 87% are virally suppressed, and 78% are virally suppressed, and 87% are already linked to care. So I would say generally as a country, we are on course to achieving the UN targets of 95.
So why is Nairobi a concern then? Because you were reporting yesterday that there seems to be an increase in infections in Nairobi. Is that what you found out?
This is in terms of absolute numbers. If you look at the numbers that are being given, Nairobi County with new infections of 3,045 looks to be the highest. But again, what is the denominator? It's against 4.3 million if we project from the Nairobi population of the 2019 census. And Nairobi is one of the counties where there is a lot of influx of people during the day, and therefore during the day it could even be going up to 7 million. And these people will seek services, majority in Nairobi. So this data we are seeing for Nairobi is actually against a denominator that could be 6 million, that could be even 7 million. And if we look at the prevalence of Nairobi, it is 3.7%. and the national prevalence is 3%. So it is not so high, it's just close to the national target. But it is the absolute numbers which seems to be high in view of the denominator, which is the high population of Nairobi City County.
In simple terms for the layman, there's an increase in infections in Nairobi, right?
In simple terms, there is a decline because the prevalence in Nairobi last year was 4.2, and now we are talking of 3.7. So Nairobi City County has actually had a response that has led to decrease in the prevalence. And the prevalence is what we use to measure in our population because it's a percentage of the total population. But if you look at absolute numbers, it may deceive you because the denominator is big. Yes.
Interesting. Dr. Kinyanjui, how would you describe the current state of HIV response in Kenya?
I find it interesting. I find it interesting that I find it interesting the way my colleague has interpreted the numbers. But I appreciate that he's taking a trend for the last 5 years. But I would go that long if we were looking at a steady trend. But the trend over the last 5 years has had ups and downs. And we are concerned as an NGO and the other people in civil society because of the numbers we've seen over the last 2 years, 2023 and 2024. We've seen the curve is not smooth, going down. We've actually, the last 2 years, we've actually had data going up. If you look specifically on the numbers, the numbers of absolute numbers, I think 2023 it was either 16 or 17,000. And this year, last year's data you can see, you can appreciate is very close to 20,000. So there's almost like a 3,000 in absolute numbers of new infections. The other thing that makes us get concerned is also the mortality, which has almost like stagnated around 21,000 during these years. We are also concerned that the EMTCT, that is the transmission of the virus from mother to child, has also actually over the last 2 years, I think, has also increased from 7.6 to around 9.3 now. So, and when we looked at specifically, I know we are concerned about Nairobi, but we have major reason to be concerned about the ASAL counties, where the mother-to-child transmission rates is double-digit. Some of them over 20%. I think we can look specifically on the counties, but that's a major, major, major concern.
Okay.
So we are concerned about that. And the other thing that we are concerned is about the insecurity that, I know Cleopatra is here, that clients are expressing about them not being very sure whether they will get their medication next time. There are also concerns due to the integration of services that is not guided by a national policy. And as a result, each county is doing whatever they consider best. Some of them including closing of clinics and sending persons living with HIV to the general patient, where they are lost because most of the staff working there over the year have not had the requisite training or experience, and they find themselves inadequate to take care of them. The clients can feel this.
Okay.
So, and the other thing, we did not communicate properly this integration. So most people don't even know what is integration. So they actually, any facility, they hear that facility, there is integration, there's mass movement of clients out. I can say this confidently because for the HIV clinics that we support in Nairobi County, which is mainly Mathare and Parklands and St. Mary's, we've seen more than 1,000 clients come from other clinics and self-transfer them into our AHF-supported clinics. Okay. So strongly appreciate the fact that they feel uncomfortable with an integration they do not understand. They actually feel exposed and like they're being forced to disclose.
What is integration?
Now, that's a big question to ask because if you ask me, I'll give you my interpretation because we do not have a policy guideline to guide what do they mean by integration. By integration, my understanding of it is that we would want all persons who have chronic illness, who live with a chronic illness, diabetes, hypertension, HIV that is already stable, to go to one clinic. Queue on one queue, be seen by the same doctors, so that when we are queuing like this, if we are your clients, nobody would know why we are here. My colleague here, my senior colleague here would be may be coming because she has pressure. I may be coming because I am HIV positive. Dolo may be coming because he has diabetes, and Cleopatra may be coming because she has asthma. But when you are queuing like this, nobody would know, and this would kill stigma.
Okay.
But when they're being pushed into an outpatient to queue like patient with flu, somebody with jiggers, somebody who came because he has worms and things like that, or pneumonia, it is unfair to them. And that is not the way we manage all other chronic illness. Okay. We've been trained on how to manage the chronic care. Is a relationship. There need to be a very clear arrangement of this, which is not happening now.
Okay. Dr. Mbajo, what have you been seeing over the years? And there's a different trend that's happening now where people prefer to use rapid test kits.
Yes.
Do they work, first of all?
So, thanks, Trevor. So when we think about testing for HIV, for a long time testing was facility-based, either in hospitals or standalone testing centers. But over the years, there have been development of self-testing kits as well, and these are available in country. Self-testing kits come with anonymity. Someone can test without other people knowing. And they're basically good screening tests so that if someone is positive, they can then seek care. They're not meant to take the place of taking care of yourself, that if I test and my partner tests negative, then we're all good to go. But self-test kits are available and can be used, and they work. And really, it's meant to help with screening so that if someone is positive, they can get care early. The concern is where people use the test kits, and because someone is negative, then they're not taking any protection. They will not use condoms and the rest. And I think it's just a reminder that the test kits only test for HIV, but there are other sexually transmitted diseases other than HIV. So where there's a lot of people not taking care of themselves is when we'll start to see an upsurge in infections like syphilis, gonorrhea, and the rest. So it's really to be aware that there's more to sexually transmitted infections than that, just HIV.
Yeah, and Dr. there was an argument we were having with some of my friends. It's a layman argument. But the issue was, if you're exposed to HIV maybe like a week before, so these test kits can't really pick it up, can you still transmit? So, even if the test kit shows negative, can you transmit to your next partner because you exposed a week?
Yeah.
Before.
So the way it works generally is if someone is exposed to HIV now, then the usual tests we use may not pick the positivity because it takes a bit of time for the body to produce what we call antibodies, you know, the HIV virus. So the body produces something to attack the virus, and that's what is picked by most test kits. So if you test too early after exposure, you may have false negatives for a short while. The period shortly after infection is also associated with the time when the level of virus in the body tends to be high. So yes, transmission can occur during that time before some of the commercial test kits become positive. Over time, the test kits are improving, so they're able to pick certain things earlier. But there's usually a short period of time when you may have a false negative, and even then we advise that, you know, someone tests not immediately after an exposure, but even up to a month or more after the exposure. So yes, there may be that risk that where people do not take care of themselves, there could still be risk of transmission. And I think we have to go back to the basic messaging around prevention. It's not just, oh, we are going to use the tests and that's it. Everybody has to take responsibility for themselves and think about how they protect themselves. Do they know their partners? Are they able to use protection? And where there's inadvertent exposure, can they come in so that you're able to advise on what can be done to prevent infection? Okay.
From your analysis, are we seeing any mutations with this virus, or has it been constant over the years?
So the virus is generally constant. So we usually like to refer to the virus as a wild type virus. That's the one that hasn't changed. Most of what we see is where the virus changes in response to interrupted treatment. So for example, if someone is on treatment, the way treatment works is that it has to be taken every single day. That's a treatment that's available in country. As science improves, we may have treatments that are given less frequently. But at the moment, what we have in country is treatment that has to be taken every single day. So if someone doesn't take their medicine every day, people get tired, they forget, and other things. So if someone keeps interrupting the treatment, then the virus mutates. It changes its characteristics so that it becomes resistant to the treatment. And that's a concern because then the options for treating that person are fewer than if they had what we're calling the wild type virus, the one that has not developed any resistance to the drugs that are available.
Interesting. Cleopatra, let me bring you into this discussion. You see now that adolescents and young adults seem to be bearing the highest burden of the new infections.
All right.
What are the key drivers and how can it be addressed? What's going on within your peer group?
All right, thank you so much for having me. And I will start by saying that it's quite unfortunate that the doctors here are doing a lot of work, but we are still having infections among adolescents and young people. This doesn't mean that nothing has been done. A lot has been done. We are not where we used to be, but from what I've heard and what I deal with young people every other day. But we've normalized. Tumenormalize young people wanaogopa kupata mimba kuliko kupata ukimwi. That is what they say. I will use that. Because people assume that treatment, wanasema dawa ni moja tu. So, unaweza take dawa, haina shida, it's just one. But what we want to tell people is that long life treatment is not easy. I've taken drugs from when I was 13 years. It's not a very easy journey, but people assume and tuko na hiyo tendency, and this generation yetu si kama ya kina daktari, sisi hakuna hawaogopi anything. So that ignorance, and again the information that young people have, they have the information, but they don't have the correct information. I will echo what Dr. has said. we have so many preventive measures. There's PrEP, there's PEP and all that. Young people, mtu ana assume akitake PrEP, may prevent everything else. They don't want to use condoms. We keep telling them that consistent and correct use of condoms will prevent, will give you 99% prevention against HIV, unwanted pregnancies, and of course STIs. But that is not what they want. And again, there's the tendency of this generation we want. And if you find those infections, they are not coming from new generation, from other, kuna wasichana, kuna wababa, kuna vijana, kuna wamama, and all that. And poverty and trying to fit in. Tuko na generation yenye watu wanataka kupata vitu haraka haraka. And so if someone, and you'll find young people, a young girl telling you, I met someone, they want to have sex with me, they don't have they'll give you money, they don't have the ability to consent, or not they'll consent, they don't have to negotiate for condom use and all that. So we have so many factors that are driving this, but I think a lot of information is there, but they don't have the correct information, and the ignorance too, and the assumption. But what we can do, we are supposed to be giving this information. I'm happy we're having this conversation juu tukiwaambia ukweli, because we cannot instill fear. Mimi nikisoma, I didn't even know when I was in primary, I didn't know I was positive. But we used to have those images that really instilled a lot of fear to us. But we cannot use that to this generation right now. What we need is to tell them the truth, to tell them that HIV is there, to tell them that there's medication, but long life treatment is not easy. To tell them that you need to use, we have preventive measures. We have all those friendly services. We don't want young people, if someone has, is exposed to getting pregnant, that means they had a very high chance of getting an STI, of getting HIV. That is the information we are trying to pass. But until we close all those gaps, hakuna mahali tunaenda, na we will keep getting the rise in the infections among adolescents and young people.
Yeah, Cleopatra, I find that interesting because first of all, young people say wanapima na macho, wanakuangalia wanasema una kafiti sana huwezi kuwa tuko na HIV.
Yes.
But then the issue around the stigma versus the fear. Like when you're growing up, the images of someone who's suffering from HIV were extremely distraught.
Yes.
And that would instill fear.
Yeah.
But now that fear is translated as stigma.
Yeah.
So where do you draw the balance now? Can you still...
We can do that by giving the right information.
But they are not scared of it. You just said that.
And they're ignorant.
Because there's one tablet, I can handle it.
Now, we want to encourage, personally, I'm a very good ambassador of condom use. Yeah. But again, you know that Katam, I can not use that term that they usually use in terms of using condoms. They don't want to do that. But we still want to encourage people to go for testing. Most of these infections are coming from people who do not know their status. Because I was trying to ask even Daktari, why is it that I am undetectable? I've taken medication, I cannot infect. We have good drugs that when you take, you become undetectable. Where are we getting these infections? These infections are coming from people who do not know their status. Can we encourage people to test? And watu wa young, not unless mtu apushiwe sana, they will not walk themselves into a facility and get tested. And again, you've mentioned about self-test kit. They're there and they're available. But that is a screening kit. Wengine wanasema sasa venye tu daktari amesema you'll screen and that is it. Unasema uko sawa. Until next time, that's when we'll do that. So let's encourage them to get tested. Let's give them the right information. Yeah. Kuna wenye wote hawatasikia, but kuna wengine wataskia. But of course, the ministry is doing a lot of work. People like Dr. Kinyaji, they're doing a lot of work. And we have facilities which are youth-friendly, yenye watawork. Because young people wanaogopa, nikienda hapo nipatane na mtu anakaa kama mama yangu, haizi mwambia anything. They will not even say about the exposure. Some get even abused. They will not report. They will not talk about it. Okay. And after that, we have prophylaxis that people can get. And we need to close all those gaps. Hizo gaps ziko. Tuambie ukweli, mimi who feel everything as a young person. The information that I've gotten right now, if we pass it to this young generation, we will have saved one or two. Okay. We might not get all of them, kwa sababu si wote watakubali, but we'll have. Let's give them the right information. Let's encourage them about testing. Let's create an environment that they feel safe, that I can walk to a facility, know my status, if I test positive, nishikiliwe mkono, start medication. And again, I usually tell them, there is so much life after testing HIV positive. Knowing your status is taking responsibility of your life. It doesn't matter the results. If the results are positive, you have another chance to take medication, become undetectable, continue with your life. If your results are negative, you have another chance to continue putting the preventive measures to maintain the same status.
Okay.
That is what we need to tell them.
Yeah, let me bring in Dr. Ndolo on this. You are the ones who did this research, and the report shows that about 74% of all these new infections, you're arguing that the numbers in absolute numbers, it's not a rise per se, but that infection, 74% is within the age group of 15 to 34. But there's also something Dr. Kinyanjui mentioned, mother-to-child transmission. You would think that this age group is the most informed. But how come there's still rising infection within that same age group? What did you find out and what did you recommend?
Yeah, okay. Maybe we were not clear on where we were interpreting the data in terms of the percentage.
Yeah. I
think we were interpreting the Nairobi County percentage. But now in terms of new infections, 15 to 34 being 74%, that's actually the reality. And she has addressed most of the issues around the young people. And one of the things is also attributed to the success of the rollout of the HIV program, because with time, those photos which were being shown those days, nowadays with good patient care and the rollout of the programs that have been put along by the ministry, people are able to be on drugs, and actually they will not be as thin or living with any issues as it was before. So we have a young generation who have not seen somebody with AIDS, which is the end stage of the HIV disease. And therefore then now the issues she's raising then comes up. And this is actually what we are seeing, many young people. And this is what informed the national theme for this World AIDS Day, which is one race, one goal, ending AIDS among adolescents and young people. And that is what we are emphasizing on currently, on the testing, and the drugs are available in the health facilities. And just to talk about what Dr. Kinyanjui raised about the integration, it is true that the interpretation of integration of services has not been understood by many healthcare workers in different places, and many counties have interpreted it differently. However, yesterday, as we were doing the National Half Marathon, we also launched the Kenya AIDS Integration Framework 2025 to 2030, and the integration is not a fixed prescription from the national government to everyone in the country, but it is offering options of integration based on the health facility infrastructure and the number of patients that are there. So for some health facilities, you'll find it is possible that the HIV clinic can be integrated together with the hypertension, diabetic, chronic care clinic, as the doctor has explained. That's Dr. Kinyanjui. Yeah. But then you can go to a small facility which has like 20 patients, and so only maybe 2-3 clients come every week. You see now, in this case, you may not have a special clinic for these 3 patients every day. So this one may have now to integrate through outpatient. So in this document, the Kenya AIDS Integration Framework, you are able to pick what works for that particular facility. And actually, that is what the Constitution says about healthcare, is a default function, so that the counties can make decisions based on the actual circumstances on the ground. I can say that the integration may at some point have been rushed in certain facilities because of the change in the donor landscape, which happened abruptly, and the services had somehow to continue. So at that point, there was some interruption, and actually the National Endemic Diseases Control Council, together with the counties, we did a rapid resource initiative to identify the problems that came with that interruption. And what we found is that actually that movement of patients, everyone to outpatient, was a key concern to the patients, and also the clinicians who were there were not like well equipped with the knowledge. So now, as we address an integration, we are looking at the entire 6 pillars of healthcare provision. So you want to integrate through the leadership of the counties, of the health facilities. You want to integrate the service delivery. You want to integrate the information management system. You want to integrate the financing. And you want to integrate the issues of the commodities and the space. So it's a whole spectrum, and we need to walk this path slowly. But the most important thing is first to ensure there is no interruption in service delivery and no one fails to get medication, no one misses an HIV test when they need it, because we are talking about integrating services.
Okay. Ladies and gentlemen, I have to take a quick break. When we come back, I'll come to you all for solutions now. We've given the general overview of where we are. What do we do now? So I'll give you each about 5 minutes to just explain what we need to do from this point on to deal with the HIV and AIDS. But that is right after this break. You can send in your views as well at Trevor Mbidi at Citizen TV Kenya. Use the hashtag Citizen Monday Report. See you in just a bit.
Watermelon, yes, please. Captain, pineapple sizzle, big vibes, banner. Hold up, Tulia. Did he just dip that wing into his captain in cola? Sheesh, love it. However you spice on.
This festive season, discover a city that never stops shining. Dubai, where every skyline tells a story and every evening feels alive with possibility. Because the true sparkle of the season isn't the city lights, it's the joy of discovering them together. From just $1,740 per person sharing, enjoy 5 unforgettable nights, rooftop dinners, desert safaris, shopping adventures, and memories that linger long after the journey ends. This December, celebrate connection, gratitude, and joy. View travel, moments that matter, memories that last. Every Friday, 10 p.m.
Unajua ni kudunda kudojo.
Bigger statue. Salam Konko. Like people, are you ready?
Akufa juu, kila mtu hapa ndani kufa juu.
E for the energy.
E for the vibe.
Say E for the energy. Unaweza niita media messiah Stombora.
Coast Africa's mega hype man. Good man.
10 over 10 every Friday from 10 p.m. 10 over 10, spiced by Captain Morgan Gold.
Hold up, Tulia. Did he just dip that wing into his captain in cola? Sheesh, love it. However you spice on.
It's big, bigger than you can imagine. It's massive. It's the biggest jackpot. Shabiki Super Jackpot Sahini 100 million. Yes, predict 17 games na 99 bob na ujishikie 100 million. Bonuses ni from 13th correct prediction. Na ukipata zote wrong, usiwori, bado kuna bonus. Hii ndio jackpot. Shabiki Super Jackpot is now at 100 million. To play, download app ya Shabiki on Play Store or SMS SJP to 29063.
Gaming is addictive. Play responsibly. Not for persons under the age of 18. Shabiki.com is authorized and regulated by BCLB. License number BK 0001080.
Get out of my house right now! Get out! You're not welcome here! Get out! Don't get anywhere! One no longer wants anything to do with you, because he's finally understood that he has a life ahead of him, far away from you. Leave him alone, and don't ever bother him. Attorney! Are you alright, Attorney?
DSTV makes wherever you are the best plan for the holidays.
This festive season, get your DSTV decoder for only 850 Kenya shillings today.
Every Friday, 10 p.m.
Unajua ni kudunda kudojo. Piga statue. Salam konko.
Akufa juu, kila mtu hapa ndani kufa juu.
E for the energy. E for the vibe. Say E for the energy. Unaweza niita media messiah Sombor.
Coast Africa's mega hype man, good man.
10 over 10 every Friday from 10 p.m. 10 over 10, spiced by Captain Morgan Gold.
Hold up, Tulia. Did he just dip that wing into his captain in cola? Sheesh, love it. However you spice on.
All right, thank you for staying with the Monday Report. The conversation is still happening on the World AIDS Day as Kenya joins the world in marking the World AIDS Day. And let me get to the recommendations going forward. Dr. Kinyanjui, so where do we start? Now we know the general overview of what we're dealing with. What do you recommend going forward to deal with this HIV infection?
Yes, I think I'll try and borrow a Kiswahili msemo. Mtegemea cha nduguye hufa maskini. If we continue depending on partners, on donors to handle this matter for us, then we are going to lose the fight. Even when we are so close to 2030, even when we have come so far and saved many lives, all these gains can be watered down in a very short time, a couple of years. We ask my senior colleague here, Dr. Obedia, is that easily for interrupting treatment, we can have a lot of the people who are on treatment now. The virus in them mutate, it becomes a resistance, and the first-line drugs will no longer work. And we can start seeing double-digit increase, thousands of people getting new infections, and thousands of people dying afresh because the drugs we have are no longer working.
And that's in a short while from now.
It's in a short while. Yes, it's in a short while. It doesn't take. I don't think it will take 5 years. It will take less if we cannot be able to retain these people on the effective treatment. So what we need to do, it is time to invest our own money. And I'm calling it investment. Not that it's a misstatement, it's a statement of fact. We are investing now to prevent the numbers that become, we were looking up at numbers, and it cost the government currently with the ARVs continue being provided mainly by the donors. The government just need to invest something like between 5,000 and 10,000 per person who was already infected to retain them on care. 5,000 is the amount of money pledged under the chronic care under SHA. So if we just start there, enroll all clients, persons living with HIV under SHA, allow them to get the 5,000, the counties will be able to, county facilities will be able to deliver very good care. And we will not keep fighting about how many staff to employ. The counties, hospitals are able to manage this. But right now, they consider persons living with HIV as the responsibility of the national government and not their own responsibilities. And therefore, they are not investing. If you look at where the clinics are for HIV clinics, they're in the broken parts of the hospital. If you look at the staff who are given to the CCC, they are the least productive, old, sickly, discipline matters. So, but because they are not paying FIF, if they were paying FIF, they would be treated better. But they don't need to pay FIF because they are talking about using social insurance to take care of these chronic conditions. And SHA is our platform for now. So my question I want to ask here, I hear there are lots of questions, how much would it cost and so on. But we've just been told, we already know that only 3% of people living in Kenya have HIV infection. 3%, that's the number. It is estimated that anything between 4 and 5% of Kenyan adults have diabetes. So that's a much bigger number. But wait until I mention the hypertension. We are talking 20 to 24%. That is 8 times the number of people living with HIV have hypertension and they need to be treated. How is it the government can accommodate the hypertensive, 8 times? And just say that taking care of people living with HIV is expensive, may bankrupts SHA.
Isn't it because we've relied on donor funding for the longest
Is it
time?
because we've been relying because of donor funding?
Yeah.
Let's start by just saying they access the same package like anybody else with chronic care. 5,000 shillings per year. It's 7 billion in a year. Is that too much to ask?
Okay.
To save our generation, to save our future?
All right.
I don't think it's much to ask.
Okay. Dr. Mbajo,
Okay.
your recommendation?
Yeah, thank you. So I think my recommendations is for people, for us. And what's the key message that we should take from this World AIDS Day? I think the first one is around prevention. Let's prevent it so that it doesn't have to become a problem for us. And prevention, when we were in school, we were taught the ABCDs of prevention. We've sort of moved towards the D and forgotten the ABC. So it was abstinence, being faithful. Then after that, we have the use of condoms, and we have drugs that we can use for prevention, either given before exposure or after exposure. So where someone feels they've been exposed, they can go to the hospital and ask about that. But you cannot forget prevention. There's also prevention of mother-to-child transmission. I think it was mentioned earlier that the number of new infections we're seeing in newborn babies is high. And it's really tragic in this day and age to have a baby born with HIV. It starts a life of difficulty and lifelong treatment. It is not easy. So that's one area we must prevent. And it is very possible to eliminate transmission from the mother to the child. So we really need to think about, for any mother who's positive, go to a hospital, take your treatment, get your viral load checked, deliver in the hospital so that you're able to start the baby on prevention early, and it will be possible to eliminate transmission. The other message for me is around testing. So I think people are scared of testing, probably because there's still a lot of stigma associated with HIV. But testing and early treatment is important. I think one of the other tragedies that we see in caring for patients right now is we have people presenting with what we call advanced HIV. We're beginning to see the face of AIDS that was seen in the 80s and 90s because people are presenting late for care. And when one presents late for care, then you come with TB, meningitis, and many other infections that could easily have been avoided if treatment was started early. So testing is not for certain people, it's for everyone. The third thing is around treatment. So treatment is available. I know there have been a lot of concerns, and a lot of my patients ask me this around, now that they've heard about the funding issues, are they going to die? Is there no drugs? But there is medication in the country, and it's going to be there. So people should not hesitate from taking treatment. I know there's a bit of discussion around integration, and I just wanted to clarify. You give me an extra minute to clarify that. So the way HIV programming has worked in the country is that HIV clinics were standalone, separate from the rest of the hospital. But that required that a lot more funding has to be spent to maintain a separate system within the hospital. But I think as we see these challenges with funding, we have to think about how do we integrate this care of HIV into the routine hospital, whichever model that is. It could be that healthcare workers rotate through these clinics, or that patients go through, the usual routine clinics. But it would help with stabilizing at a time when funding is unsure for the future. I guess the other thing is around, for those who are on treatment, stay on your treatment. HIV treatment is lifelong. I get a lot of questions about cure and about injections that can treat me, and I never have to take medication. In country, we do not have injections for treatment routinely available. We have some for research perhaps, but not routinely available yet. But stick to your treatment. When people stick to treatment, they're able to live long, healthy lives. But if you keep interrupting treatment, then a lot of complications.
Clarify that for a bit, because there was a report that in 2026, Kenya is looking to test out injectable HIV. So what is that, and where are we?
So what we're looking forward to receiving in 2026 is an injection for prevention. It's an injection that will be taken twice a year, so once every 6 months. And research in multiple parts of the world, including large African studies, have shown that with this injection, prevention is practically 100% sure if it's taken.
For 6 months?
For every 6 months, an injection once every 6 months, instead of 2 injections given at the same time every 6 months. So we're looking forward to that becoming available in the next year or so. Yeah? So that will be another tool in the prevention shed. Not forgetting the ABCs, but will be another tool in the prevention toolkit. So that's one. When it comes to treatment, and this is a question I get very frequently, is there an injection for treatment? And in country, we do not have one routinely available. The best that's available is a 2-monthly injection. So someone would still have to come for 2 injections every 2 months. It's not available routinely in the African market. So maybe in the US and Europe, there are countries that have it as part of their programming, but it's not available to us yet. What we have in country is a daily pill.
Okay, so the one in 2026 will come in and
it's for prevention. So before someone gets HIV. So if you know you're at risk because maybe you have partners whose status you do not know, or someone has multiple partners, or someone is in a relationship where they're unable to negotiate for, condom use or other prevention, then that would be ideal for that population.
And when do we expect this?
I think the indication is that it may come maybe towards the end of 2026 or early 2027. But yes, we expect that in the next year or two, it may become available for routine use.
Thank you for that. Dr. Ndolo, your recommendation?
Thank you, Trevor. I think the first one I need to do is to assure Kenyans that the ship is steady. And as my colleague here said, my senior colleague, who was also my teacher, we have adequate drugs in the country. And in terms of the funding for the drugs that come to the country, there is a component that the government of Kenya provides, and then there is what we get from the other entities that support us, like Global Fund and the likes. So we have already done this costing. Now, in terms of recommendations, we have already done this costing, and we know what the country would need if all the support was removed. So
what does the country need? How much?
It's coming to 28 billion.
28 billion a year?
Per year. Currently, we are investing around 4 billion.
Okay,
because
so we have another 24.
Yes, there's another 24. But from the indications, progressively, the support that we get is not stopping today, immediately. So we are already having that visibility of what we need. I think it could be worse if we didn't know what the donor is giving us and what we do need. Then the next thing is about that integration. Again, my teachers explained it well. Maybe you are talking too much medicine in it. It basically means remove it from being a separate program and integrate it into the routine care. And when you do that, the costs will again go down. So this 24 billion deficit we are talking about coming from donors, it will actually go down because now this system will be put together with the other health systems. So, and that is the document we launched yesterday to guide the country and the counties on the integration of the services. And this will do it gradually so that we don't lose anyone. Again, the issue of losing someone to care, Dr. Kinyanjui has explained. Then the other thing that we are going to do as a country is stakeholder involvement. We involve as many stakeholders as possible. And in the Ministry of Health, National Systemic Diseases Control Council, one of the mandates is stakeholder coordination. And from the time we started getting these uncertainties, we have convened our stakeholders in the HIV sector so that we have a unified approach as a country for everyone to be involved. That's why we have Cleopatra here, and our colleagues here, AHF is also here, so that we can all agree and move in one direction. And one of the things that we are doing is domestic resource mobilization. Dr. Kinyanjui has talked about SHA. Currently, we are reviewing the essential benefits package so that if there is a component of HIV care which is not in the current package, we can see how it can also be integrated. And currently, SHA as it is, there are some components of HIV care that it caters for. And I think sometimes because of that vertical nature of the program being outside the health facility as a clinic alone, they start thinking like now SHA cannot cover anything. But the truth is, if you want to go to the lab and do some basic investigations for liver, for kidney, for urine, for stool, all those are in the SHA package as it is today. Okay. So it is just shifting the practice so that we align and we integrate the service inside the existing frameworks. Okay. Finally, from our stakeholders, they have proposed several things that the country can look at, and we are compiling the report, including looking at donations like and other preventive commodities like the condoms, if we can have a review of the tax waivers, and then if we can explore local manufacturing of condoms and also ARVs like other drugs to reduce the quantities. That is what the communities have said. And then finally, as part of enhancing the stakeholder mobilization, every county has a multi-sectoral coordinator who we work with, who is an employee of the county government. And through them, we are able to get what is happening in the primary care networks and take the conversation of HIV care and treatment and prevention to the multi-sectoral networks. Okay. So that when they meet at the sub-county level, there is someone talking about HIV. And this is part of bringing HIV to the routine care. And this way, we will be able actually to tackle the issues to do with HIV and not have it as a separate disease, but move with all the other issues in the ministry.
Okay. Cleopatra, your recommendations going forward, what do we do now? We know where we are.
Now, I want to speak, and of course I'm speaking to you, to speak on behalf of young people. And I want to start by saying there is no single intervention that will work. We need to have so many interventions. And I'll start with one, that we need to pass the right information. That is the education. When we used to grow up, we used to have, even when I started my clinic, kulikuwa na a lot of awareness. I think that stopped. A lot of things that were creating awareness, that is one. And then Dr. has talked about preventive measures. People know about most people even, you've mentioned about Lena, the injectable. Watu wanasema ni cure. They don't have the correct information. Wanasema, si dawa inakuja. Watu naonanga wakinitext, dawa inakuja, so tuko sawa. Let's put all the preventive tools in order, and condoms, make them available for young people. We cannot tell them to abstain right now, Dr. We cannot. We cannot. They will not.
They will not abstain.
So we cannot tell them to abstain. It's the first preventive measure that we have, but they will not. So if you cannot abstain, what do you need to do? You cannot abstain, you cannot be faithful. Use condoms. Let's make them available. Dr. Bring them, give us. Tutawapea mpaka kwa mtaa. The other thing, we need to have empowerment. The third one, let's empower these young people. There are no jobs. That is why we are getting those funny things. Watu wako wamepata mbaba, they cannot negotiate for a condom. That person is giving you money. And you'll find when it gets to that point, these young girls and young boys need empowerment. The next one is that we need to create youth-friendly services. And I'm very happy I can applaud my boss here, Dr. Kenyaji. We have a clinic at AHF Madari where STIs screening and treatment, it's free. Absolutely, you walk to that clinic, hata hatutaki SHA, unaingia tu hivyo, venye uko, everything you'll be screened, you'll get treatment. This is what people want. Because hutaniambia a 20-year-old akona STI, it's very expensive, daktari, for the testing. They won't afford that. Let's make youth-friendly services for them. The fourth one is that we need to stop stigma. The reason most young people are not even adhering to medication is because of the stigma. I always say that when you stigmatize someone who is infected or living with HIV like me, or anyone at the risk of infection, these young girls and these young boys, you're not helping us, you're not helping daktari, you're just fueling the epidemic. So all those, hakuna yenye itafanya peke yake, all those interventions, they are very good, very nice. Tunakujanga hapa, tunaongea, madaktari tunaongea, but if we concentrate on the preventive measures and we don't give the right information about the preventive measures, bado haitafanya kazi. You'll find people going, having unprotected sex, taking PEP, but they don't know that PEP will not prevent you from getting unplanned pregnancies. It will not prevent you from getting STIs. You'll get people using condoms, but inafika wakati wanasema si poa, they use them and they assume iko tu sawa. So let's give those. And when we do that, we'll have informed young people, empowered young people, skilled young people, and we will be raising a generation that is healthier and safer.
All right.
Thank you.
Thank you so much. Let's bring up some feedback, some quick feedback here as we wind up on this conversation. And Trevor Mbidi at Citizen TV Kenya, use the hashtag Citizen Monday Report. Let's bring that up on your screen and see what you're saying. Okelo Mwalimu says, Trevor, please ask the doctor what specific gaps the research attributed to the rise in mother-to-child HIV transmission. Also, please, could the doctor advise on whether an HIV test should be repeated on admission or if the one done during ANC profiling is sufficient? Let's get this reaction from the doctors really quick. So please ask the doctor what specific gaps the research attributed to the rise in mother-to-child HIV transmission.
Okay.
Yeah.
All right, so a lot of transmission, that's a really good question. A lot of transmission happens during breastfeeding and or during the childbirth. And many of this is because people did not know their status. So some of the testing is being done at delivery, and there are many gaps in that testing. So the women who are still giving birth and who do not know their status. So really ensuring NC visits happen, really encouraging people to go to clinic when they're pregnant, because clinic will offer HIV testing. If we know someone's status during pregnancy, we can put in all the measures in place to protect that baby. But if someone is delivering and they've never had a test and we're discovering at the point of delivery, then the risk to that child is really high. So really people getting clinic and getting tested during clinic is really, really critical.
Yeah, there's a second part of that question.
About the repeat test. So if someone was tested negative when they got pregnant, during the first month or second month of pregnancy, we really want to repeat that test because of the reasons we've said. There's transmission that happens during pregnancy, so just because a test was negative at the start of pregnancy doesn't mean at the end of pregnancy that test is still negative. And as I said before, it's really tragic to have a child born with HIV in this day and age. So yes, the testing will be repeated as soon as they come to NC. If it hasn't been done, we try and do it before delivery so that we put the right measures in place to protect the child.
All right. Dr. Kinyanjui, you have something to add? Yeah.
Yes, I want to add the reasons why we believe the PMTCT, what Dr. Banjo has explained is absolutely true, that when the testing is done, I want to add two things. One is that sometimes the mother comes for ANC a week or 2 weeks to deliver. It is too late to put in treatment because it takes something 4 months to 6 months for the viral load to go low, so that reduce the risk to the baby. So that's why we insist on mothers coming as soon as they suspect they're pregnant.
Okay.
Number two is when you see where this mother-to-child transmission is very high, it's most of the arid counties. And it's unfortunate that during the heydays of funding from PEPFAR and others, these counties most of the time were ignored. They were saying they have very low HIV transmission, and therefore the communities were not engaged and the intervention were not done properly. So there is very limited knowledge there and capacity. The next thing is some of the traditional, I would say, our cultural practices. A lot of these counties also tend to marry off literally children, underage girls, who cannot even go to the ANC without the approval of either the husband or the mother-in-law. So even they will not go to deliver in the hospital if they've not gotten this approval. So as a result, the transmission is very high. They're also children. So literally, the system, the reproductive system is not apt.
Okay.
Yes.
All right.
So, and also the level of knowledge, level of education is also a factor. If you notice, most of those ones, most of them may not even have had even primary education.
Okay.
Yes.
Johnson Sakaja, the governor for Nairobi County, is telling me that I really want their prevalence to have increased. So just clarify what that is.
Yes. What I mentioned is that the prevalence for Nairobi has actually come down.
It has decreased.
It has decreased.
Okay.
It was 4.2. Now it is 3.7. It has gone down.
Okay.
But as I've said, when you look at the absolute numbers, because of the high denominator, you might think Nairobi has more infection, but it's because the population is also high.
Okay. All right,
but Trevor, that shouldn't take away from the message that we still have an unacceptably high number of new infections, and that's a gap we really need to close.
Okay. Yeah. Let's bring up another feedback and see what you're saying. Then Cleopatra will give you a chance for closing remarks. Let's bring up that John Musang says the percentage is so high because most of the parents have neglected their responsibilities in talking to these young adults concerning HIV infection. And I'd like to hear what your thoughts are about that. And let's bring in the last one here. Moswo says youths constitute over 80% of the population, so any sample of 10 people is likely to have at least 7 people. While this data does not imply that youth are promiscuous or negligent, it clearly highlights the need for all persons to take care of themselves and one another. Yes, Cleopatra, as we wind up.
Well, I'll start with the parent issue. And, well, hiyo nayo ni ukweli. All parents waliachilia walimu to do the work. And you'll find that most of these new infections from adolescents who are HIV positive, it's because, and that happens when there's that transition from where they are coming from, the parents, to high school. Most of these kids, kwa sababu they don't know how to maneuver between school and all that. But what I would like to say is that parents should play their role. Let's normalize having sexual education with our kids. Tumefanya watoto wakue, everything when you release them, you cannot have that discussion. I'm happy that parents were saizi. Maybe I can't remember whether I've ever sat with my parent and told me, you're supposed to do this, you're supposed to do this. But that is what we are not telling them. And again, if any parent has a child who is HIV positive, let's stop lying to them. Most of them don't have proper disclosure. You start telling your kid, anameza dawa, unamwambia dawa ni za kifua, dawa ni za nini, and they'll find out, wanasema, ai, kama kifua kwani sitawahi pona. So we need to do the right disclosure, and still disclosure, we didn't discuss about disclosure. It's equally one of the leading to the new infections. And the earlier, the better. Once you disclose to that child, the better they will continue their medication. And I want to say something about passing the right information. And I will, here I have my book. This is my book, and it's about my story of being born and living with HIV. In this book, I've explained about the treatment, the long life, and all those stages that someone goes through. It has the right information, and that is what we want to pass to the generation that are there. And we should tell parents to give the right information. Pia nyinyi madaktari, please equip the parents. They don't know. Analeta mtoto hapo, mnampea dawa, inaishia hapo. Let's give the right information. And I'm one believer that information is power. And once we equip even teachers in school, let's talk to those teachers, kwa sababu even a teacher has a possibility of even discriminating their child. When I went to high school, basing it on my personal story, my dad went to the school that I went to and told the principal, my daughter is taking medication, and it made it easier for me to maneuver through high school. Dawa nikiwekewa naweza kumeza. But mzazi asipoambia, huyo mtoto hata imeza dawa. That's where the treatment fails, it creates resistance, she explained, and after that, they will not get back to treatment. Okay. So we all have a role. And just like I said before, the preventive measures, we have so many of them, and those interventions cannot work as a single intervention. We need to put them all together.
All right. Thank you so much.
Maybe just one last thing.
Yeah.
Okay, it's true about the parenting aspect, but from the side of government, we are actually in the process of finalizing manuals which are age-specific for training on HIV and other syndemic diseases. We have 10 to 14, 15 to 18, 19 to 25, and above 25. And these ones which are for the school-going age, that's 10 to 14 and 15 to 19, we are in partnership with the Ministry of Education. And so as the new curriculum, the CBE curriculum is being developed, this is also will be considered so that we can also have this message being passed in the schools. But more importantly, as Cleopatra said, the parents also need to come on board. Even the churches, the mosques, and all the religious leaders, it's all approach for the entire society, also stakeholders to come on board.
Right.
But from Minister of Education, Minister of Health, we are already in partnership to embed it in the curriculum.
All right. Brilliant. Thank you so much for making time this evening, Dr. Lois Ombajo, Infectious Disease Specialist and Co-Director, Center for Epidemiological Modeling. That's a very difficult term. And analysis. University of Nairobi, thank you for making time. Dr. Samuel Kinyanjui, Country Program Director, HF Kenya. Dr. Stephen Dolo, Director, Health Promotion and Program Management, National Endemic Disease Control Council and the Ministry of Health. And Cleopatra Wanjiku, HIV advocate and founder, the voice of a black child. Thank you all for speaking to us tonight. And thank you all for the feedback that you sent through. That's why we leave it for now. On behalf of everyone who made this possible, say good night and God bless.